In this video, let's revise fetal and neonatal physiology. So to get started, we will be looking at some facts and then a most important concept about fetal circulation and then the readjustments a baby would make once it gets exposed to the external environment. We'll look at the nutrition required for the neonate and for the fetus, and we'll look at some certain conditions called as neonatal jaundice and erythroblastosis fetalis. We'll look at the immunity required by the neonate and the fetus. We will look at some of the common endocrine problems, and finally, a very interesting concept called oxygen therapy for the neonates. So to get started, we look at some developmental facts. Okay, the first fact I want you to remember is the weight is proportional to the cube of the length and the age of the baby. This is just a random fact I want you to remember. This is a revision video, so let's not get into the details of it. So simple as that, the weight of the baby is directly proportional to the cube of the length and cube of the age of the baby. Now, what about organ systems? When do each of them develop? So to have a gross understanding, let's look at first month, second to third month, fourth month, and the remainder of the 5 months. So pregnancy is basically for 9 months, right? So those 9 months, let's look at the overall view of organ system development. In the first month, there is gross development of the organ systems. That means there is a little bit development. You can see the structures appearing. In the second and third month, you can start seeing a little bit of more details in the organs. And in the fourth month, the organ systems have developed to such an extent that it is same as the neonate. Now remember, neonate is the baby which is born and the fetus is still inside the pregnant woman. So in fourth month of embryonic development, your organs will look same as the ones in your neonate. And in the remainder of the 5 months, there will be cellular development in all of these organs. See, 1 to 4 months, there will be anatomical development. And after that, to give the specific physiologic function for each organ system, there must be cellular development, right? So that happens in the remainder of the 5 months. Now, some facts about the heart. The heart starts beating in fourth week of pregnancy or fourth week after the fertilization. So when it starts beating, the rate of the heartbeat is approximately 65 beats per minute. But just before birth, the heartbeat of the baby is very fast to a rate of 140 beats per minute. Okay, so it starts at fourth week after fertilization, and when before birth, it is 140 beats per minute. These are some important facts to remember. Now, what about formation of blood cells? In the third week of pregnancy, you will have the appearance of nucleated RBCs. Now, if you recollect, RBCs are not nucleated. They are enucleated. So these nucleated RBCs will become non-nucleated RBCs by the fourth or fifth week. And in the sixth week, the liver will start producing blood cells like your RBCs and WBCs. And in the third month, your spleen and lymphoid tissue will start producing your blood cells. And finally, after 3 months or later, your bone marrow will take over. So first your liver, second your spleen and lymphoid tissue, and finally your bone marrow will take over. Now these are just facts and time periods that you have to remember. Now, what about the respiratory system? Now see, when the fetus is inside the amniotic cavity of the mother, there is no respiration possible. There is no respiration possible because it is surrounded by amniotic fluid. Okay, so that is the reason why there is no respiration possible in the fetus. And another fact to remember here is the fetus excretes, and that excreta is this yellow markings I've drawn around. That is called meconium. It is like feces, but in fetus, it is called meconium. And this meconium is present surrounding the fetus. Okay, now if the fetus is respiring, then there is a chance that this meconium can go inside, right? So that is why we don't want respiration to happen. We don't want this waste material to go inside the lungs. So that is one reason why the respiration does not happen in the fetus. Apart from this, the lung itself produces some secretions which will clean the lungs. Okay, which will clean the lungs. So there are two mechanisms in which meconium is prevented from entry inside the lungs. Number one, there is no respiration. And number two, there are secretions provided by the lungs that cleans the lungs. That is about the development of your respiratory system. Now, what about nervous system? Nervous system, in the third and fourth month of your pregnancy, the reflexes start to be active. All the spinal cord reflexes and the brainstem reflexes starts being active. And after 1 year of postnatal life means after birth, after 1 year, myelination of the major tracts in our central nervous systems takes place. Okay. These are again facts about the nervous system that you must remember. What about GIT? GIT fully develops in the last 2 to 3 months of pregnancy in a neonate. Okay, not in a neonate, in the fetus. So it develops to such an extent in the last 2 to 3 months that it resembles the neonate. Now, there is something special about this GIT. What is it? Amniotic fluid, mucus, and epithelial cells. These are the constituents of your meconium. Okay, meconium is made up of your amniotic fluid, mucus, and epithelial cell. And this is what is getting excreted and surrounded around your fetus in the amniotic cavity. Now, the respiration in the fetus does not happen so that this meconium does not enter your lungs. Again, to revise that concept. Now, what about kidney? Kidney starts excreting urine in the fetus after second trimester only. Not after first, but after second trimester, the kidney starts excreting urine. Now, here's another fact. 70 to 80% of amniotic fluid is made up of the urine secreted by your fetus. So basically, the fetus is floating around its own urine. 70 to 80% of the amniotic fluid is your fetal urine. Now, finally, what about calcium and phosphate ions? See, the calcium and phosphate ion concentration will increase in the plasma in the last 4 weeks. Why? Because in the last 4 weeks, you will have ossification of your bones, and there will be growth, and there will be increase in weight. So look how coincident it is. For the bones to grow, you need calcium and phosphate, right? And this happens especially in the last 4 weeks. And that is why bones and your weight overall, it increases. That is why the plasma concentration of calcium and phosphate is high in the last 4 weeks. Now, this page just summarized all the developmental facts that you need to remember about fetal physiology. Now, here comes the interesting part, fetal circulation. First, I want you to understand an important concept. So for that concept, let's bring a lung here. Now let's zoom into this lung. Now in a fetus, I said, remember, respiration does not take place. So that means the lung is collapsed. The lung is collapsed. Okay. If the lung is collapsed, this lung is going to exert pressure. Okay. That is called as your pulmonary resistance. It is going to exert pressure against your blood vessels, and that is called your pulmonary resistance. So just keep that in mind. Now, here I've drawn a diagram. This might look complex, but let me simplify it for you. This box here is your heart. I've not drawn the real heart so that it might be confusing. I've drawn a very simplified version of your heart. So let's name each of the parts of the heart. So starting from here, you have the right atrium. I'm sorry, you have your right atrium, your right ventricle, left atrium, and your left ventricle. Now, what about the vessels? Let's name the vessels one by one. Starting from here, this is your superior vena cava, which is draining into your right atrium. This is your inferior vena cava. And this coming out of your right ventricle is your pulmonary trunk, okay, which is coming out of your right ventricle. Now, what is coming out of your left ventricle? It is your aorta. Fine. Now, this pulmonary trunk will go to your lungs to deliver the deoxygenated blood, whereas this aorta will go throughout your body to deliver the oxygenated blood in a normal adult human being. But in the fetus, it is not the same. It is a bit complicated. Okay. In the heart, there is a hole between the right atrium and the left atrium. And that hole is called as a foramen ovale. Okay, that is the hole between your right atrium and your left atrium. And apart from that, there are certain structures which we will look in this process. This structure I've drawn here is your placenta. Okay, and this, most of you should know this, this is your liver. As I said, this is the aorta, this is the arch of aorta, this is the branches of the arch of aorta, your brachiocephalic trunk, common carotid, and the subclavian arteries. Now, from this placenta, you have this vessel called as your umbilical vein. Okay, there is one umbilical vein, and there are two umbilical arteries. Now, you might wonder, why am I putting a vein in the red colored line? Because in the fetus, umbilical vein carries oxygenated blood. Umbilical arteries carries deoxygenated blood. Okay, it is completely the opposite. Usually arteries carry oxygenated blood, but in the fetus, umbilical vein carries oxygenated blood, umbilical arteries carries deoxygenated blood. So you have one umbilical vein and then two umbilical arteries. All of this is present in your umbilical cord. Let's say this is your umbilical cord, which connects it to the placenta. Now, this umbilical vein is going to carry oxygenated blood to your liver. Okay. Now, the liver is not going to detoxify this because this is oxygenated. Liver will detoxify only toxic blood, but this is oxygenated and pure. So that is going to get shunted. And that shunt here is called as your ductus venosus. Okay. That shunt here is called as ductus venosus. This ductus venosus is going to put the blood inside your inferior vena cava. Okay, it is going to put oxygenated blood in your inferior vena cava. Now, this oxygenated blood is going to travel along one side of the inferior vena cava and it is going to enter the right atrium. Now, again, to recollect, remember this is your oxygenated blood coming from your umbilical vein. Okay, once it comes to the right atrium has nothing to do with oxygenated blood. So what it's going to do is it is going to direct this oxygenated blood through the foramen ovale into the left atrium. Okay, from left atrium, this oxygenated blood is going to enter the left ventricle. And from left ventricle, it's going to enter the aorta. And through the aorta, it is going to go and supply the fetus's body through all these systems. Okay, that is how oxygenated blood is flowing. Now, this mainly is going to supply your head and upper limb, not your lower limb, because lower limb has less function when the baby is inside. Majority of the function is required towards your thorax, your brain, and your upper limbs. So majority of the drainage is going to be upwards, not drainage, supply, arterial supply. Now, what about drainage? Let's talk about venous blood. So let me get a blue marker here. Yeah. So venous blood from the superior vena cava, which is draining your heart, your brain, and all these structures above the level of the heart, is going to enter the right atrium. And now this is going to be directed down towards your right ventricle. From right ventricle, it is going to go to your pulmonary trunk. Okay. Now here comes the deciding point. It comes to the pulmonary trunk, and instead of going to the lungs, it is going to go through this vessel right here. Let's see why. Remember here, I told you in the fetus, the lung is collapsed and it exerts a pressure, which is called a pulmonary resistance. Now that resistance will not allow blood to go through this way. Okay, so it is going to direct blood to go through this vessel. And this vessel right here is called as your ductus arteriosus. Okay, and that is connecting your pulmonary trunk to the aorta. Now, this deoxygenated blood is going to enter the aorta through the ductus arteriosus and is going to travel all the way down through the aorta, and it is going to go through two umbilical arteries. And remember, umbilical arteries carry deoxygenated blood, and it is going to come back to the placenta to get oxygenated again. So this right here is the fetal circulation. This is before giving birth. But after giving birth, it should become normal, right? So before going to after birth, let me revise this once again very quickly for you. See, this is your placenta. From the placenta, oxygenated blood enters the umbilical vein, and that goes to the liver. In the liver, since it is oxygenated, it is not going to detoxify. detoxify it, it is going to go through the ductus venosus and join with the inferior vena cava. This oxygenated blood through the inferior vena cava is going to enter the right atrium, then it's going to go through the foramen ovale into the left atrium. From the left atrium, this oxygenated blood is going to enter the left ventricle. Left ventricle will pump it towards the aorta and supply. Okay. Now, what about venous drainage? It is going to enter from the superior vena cava, enter the right atrium, enter the right ventricle, and go through the pulmonary trunk. But instead of going here, it is going to take a right turn and go to the ductus arteriosus and the aorta. Why did it take a right turn here? Because the lung is collapsed and it has increased pulmonary resistance. So it does not allow blood to go through that direction. So it is going to enter the aorta, come down, go through the umbilical arteries, and go back to the placenta to be oxygenated again. This is the fetal circulation. Now, what happens after birth? Everything should get back to normal, right? So as soon as the baby is delivered, the lung is going to expand. So when the lung expands, the lung is not collapsed anymore. So see, after birth, your lung is going to expand. It's not collapsed anymore. So if it is going to expand, the pulmonary resistance will decrease. So blood flow will increase towards the lungs. You won't have this factor here to stop the blood entering the lungs. So blood flow will increase towards the lungs. And as a result, your aortic pressure also will increase because oxygenated blood will start to rise. More oxygen from the external environment will start. So aortic pressure also is going to increase. Now, see, this is your arch of aorta. If aortic pressure is going to increase, this will stop the blood flow from here to here, right? Because pressure is high here. So it is going to make the blood go through this direction. But that is not going to happen completely because your ductus arteriosus is going to constrict after birth. It is going to constrict. The smooth muscles in ductus arteriosus is going to constrict. And at the same time, what about your ductus venosus? Ductus venosus will become a ligament called as your ligamentum venosum. What about your umbilical vein? Umbilical vein will become your ligamentum teres. What about your umbilical artery? Due to the high pressure faced by the aortic blood, highly oxygenated blood, this umbilical arteries are going to be obliterated. By that means destroyed. And that is going to form the medial umbilical ligament. Medial umbilical ligament. Okay. So the important concepts here to remember is your pulmonary resistance is high before birth, low after birth. And after birth, what are all these going to turn into? You have to remember all that. So that was about fetal circulation. This is a very important concept. Now, other readjustments. See, there are respiratory readjustments and circulatory readjustments. We just discussed about the circulatory readjustments. After a baby is born, what happens? We just saw. So we know about circulatory readjustments. What about respiratory? See, as soon as a baby is born, the baby is supposed to breathe within seconds by its own. And the normal respiratory should appear within a minute. But if there is no breathing, what happens? Carbon dioxide starts to build up in the blood and less oxygen in the blood. And that is called your hypercapnia and your hypoxia. Now, what this is going to do is it is going to stimulate your respiratory centers. And those respiratory centers will send stimuli, which will start the breathing process again. It will start the breathing process freshly. Okay, so you need not worry. So that is why we should know this fact. Without breathing, an adult can live for 4 minutes. But neonates can live for 10 minutes without breathing. So that means they have more capability to live without breathing, and they will wait for the signal to start their breathing. But when it crosses the 8-minute mark, that can cause brain damage, especially to your thalamus and your inferior colliculi. Remember that fact. Now, see, let's just see how this happens more physiologically. Okay, this is the lungs before birth, a collapsed lung. So there should be a presence of minus 25 millimeters of mercury to make this collapsed lung expand so that the alveoli will open. You need a pressure of minus 25 millimeters of mercury. That will give your first breath. Okay, and the second breath is going to be easier compared to the first breath because the lung is already expanded. And after 40 minutes of birth, the lung is going to return to normal compliance as of a normal human being. Okay, the compliance of the lung is going to return back to normal after 40 minutes. Until then, it's going to adapt to the compliance. So that was about the readjustments that our baby had to make to be born and to survive. Now, here's another syndrome, an important syndrome called as respiratory distress syndrome. There is one concept you should know to understand this. Type 2 alveolar cells. If you remember histology, type 2 alveolar cells secrete surfactant. Now, this surfactant prevents the lung from collapsing. But in this disease, type 2 alveolar cells do not produce surfactant. And as a result, your lung collapses, and as a result, edema happens, fluid accumulation. Now, what about the fact that happens during our fetal period? This surfactant starts to get produced only in the last 1 to 3 months of pregnancy. Now, if a baby is born premature, if a baby is born in 7th month or 8th month or sometimes 6th month, the baby's lungs would have not produced enough surfactant, right? So that means that surfactant is going to be low, and that baby is going to have your respiratory distress syndrome. Okay, so premature babies are more prone to respiratory distress syndrome because the surfactant production starts only in the last 1 or 3 months of pregnancy. That is about respiratory distress syndrome. Now, what about nutrition, neonatal jaundice, erythroblastus fetalis, and immunity? Let's do this quickly. Okay, nutrition, iron. Iron is required for hemoglobin and RBC. Calcium and phosphate is required for bone. What about vitamins? Vitamins B12 is required for RBC production. Folic acid is required for neural development. C for connective tissue. You can remember CC. D for bone. E is a special one. I'll come back to that. K. K for producing clotting factors like your factor 7 and prothrombin in the liver. But apart from that, in the fetus, the production of vitamin K is not so well developed. It can be developed, but at the same time, the mother's colon through bacteria is also going to produce your vitamin K. Just a fact to remember. Now, what about vitamin E? Some experimental studies on animals have suggested that the absence of vitamin E can cause an early abortion of the fetus. Okay, that is a fact that you can remember. So, if there is a multiple choice question asking early abortion of fetus is due to deficiency of which vitamin, you can put vitamin E confidently. Now, what about these conditions? Neonatal jaundice and erythroblastus fetalis. Neonatal jaundice. See, when the baby is born, the baby's liver is not fully developed. Okay, it is not fully developed. It takes time. So the liver is not able to conjugate the bilirubin. It is not able to conjugate the bilirubin with glucuronic acid. That is not happening. So as a result, bilirubin will accumulate. From 1 milligram per deciliter, which is the normal value, it will rise to 5 milligram per deciliter. And as a result, your baby is going to have jaundice. You can see yellowish appearance of the sclera and of the skin. Okay, and this is called as physiologic hyperbilirubinemia. The jaundice happening in the newborn is called as physiologic hyperbilirubinemia. Okay, now what about erythroblastosis fetalis? This is due to your Rh factor incompatibility. Now, the baby gets its Rh factor from the father as Rh positive and from the mother as Rh negative. When this happens, the mother's body is going to produce antigens against the fetal RBCs. And as a result, these fetal RBCs will be destroyed. Okay, these fetal RBCs will be destroyed, and as a result, the baby will die. Now, okay, so these are the two important conditions, neonatal jaundice and erythroblastosis fetalis. I'm really sorry, just make a correction here. The mother will produce antibodies against the fetal RBCs, not antigens. Now, immunity. What kind of immunity do we expect in a baby? A baby is going to have lots and lots of gamma globulin. Okay, but this gamma globulin is going to be half complete by the end of 1 month. But the immune system is going to take 12 to 20 months to come back to normal. But till that, who's going to support the baby with their immune function? It is the mother. Mother through the mother's milk and through the placenta before. Mother is going to transfer a lot of antibodies into the baby. And that is going to prevent the baby from developing diseases like diphtheria, measles, and other diseases, except for one disease which is called as whooping cough. So for whooping cough, you have to give vaccines as soon as possible. But for diphtheria, measles, and other diseases, you can give after 6 months. Now, there is this interesting vaccine developed called as DTaP vaccine, or you can say it as DPT. Okay, that is for diphtheria, tetanus, and pertussis. Now, this vaccine is given 5 times to a newborn. First in 2 months, second in the fourth month, third in the sixth month, fourth in the 15th to 18th month, anytime, and finally in the 4 to 6 years of life. So this vaccine is given 5 times and in this time period. And this vaccine is against all these things. That was about immunity. Now, we just have 2 more slides, just bear with me. What about endocrine problems? Now, this gets interesting. You see, you have a pregnant mother with a female fetus. Okay. And this mother is going to take androgenic steroids. Androgenic steroids are testosterone and all the male hormones. Now, what is going to happen? Those hormones are going to go to the female fetus and it's going to masculinize the genitals. So as a result, the female will have enlarged clitoris and will have masculine characters. Okay. So just remember, if a pregnant mother is going to take androgenic steroids, or if the production of androgens is increased in the pregnant mother, the fetus, if it is female, it is going to have masculinized genitals. Okay, now let's look at what happens if the mother has diabetes mellitus. So in the first case, let's imagine the mother has type 2 diabetes mellitus. So as we all know, in type 2 diabetes mellitus, the insulin levels are high. So we have hyperinsulinemia. So when insulin levels are high, it is going to support the or increase the efficiency of your growth hormone. And this growth hormone is going to cause excessive growth and also something called as your organomegaly, in which the size of the organs increase. Whereas if the mother has type 1 diabetes, then the baby can have stunted growth and then the baby can develop respiratory distress syndrome and eventually death sometimes. Now, what if the mother has untreated or uncontrolled diabetes? Then that means that is going to add pressure to the islets of Langerhans of the fetus. So as a result, the pancreas, which has the islets of Langerhans of the fetus, is going to be hypertrophied and it's going to be hyperfunctional. Okay, so that was about diabetes mellitus in a pregnant mother and how it affects the fetus. Okay, 2 more hormones. Hyperthyroidism. Let's say a mother has hyperthyroidism. That means the thyroid hormones are more in the mother. Okay, that is going to go to the fetus. So as a result, the fetus's thyroid gland is going to produce less thyroid, right? Because already it is getting more thyroid from the mother. Now, vice versa. What about the mother has hypothyroidism? If low levels of thyroidism, that means the mother is going to depend on the fetus to produce more thyroid. So that means the thyroid gland of the fetus is going to work more. Fine. Just remember one, hyperthyroidism means less activity of thyroid gland in fetus. Hypothyroidism means high activity of thyroid gland in your fetus. Now, a general condition in which there is less thyroid hormone is called as cretin dwarfism. Okay, and in this cretin dwarfism, you have decreased bone growth and mental retardation. Fine. That was about all the endocrine problems that a fetus can face because of the mother. Now, finally, oxygen therapy. This is a really, really interesting concept. Okay, oxygen therapy is given to babies which have less oxygen saturation in their blood, which needs more oxygen to breathe. Now, sometimes there can be excessive oxygen given. Okay, more than what is required, excessive oxygen. As a result, what this is going to do is, since more oxygen is there, that is going to decrease the blood vessel growth in the retina of the eye. Okay, that is going to decrease blood vessel because more oxygen is there. Why do we need more blood vessels? That oxygen is going to diffuse and go act on the retina by itself. Why do we need more blood vessels? So that blood vessel supply is going to reduce in the retina. Now, obviously, the baby is not going to be in oxygen therapy for the entire life. So at a point, you're going to stop the oxygen therapy. And when you stop the oxygen therapy, the blood vessels in the retina are going to suddenly grow towards the retina. And during that sudden growth, there's going to be bursting off, there is going to be explosion of these arteries. And as a result, there's going to be blood all around the vitreous humor of the eye. The vitreous humor is the main jelly-like substance inside the eyeball, right? The blood is going to occlude the vitreous humor, and that blood is going to become fibrotic in nature. As a result, it is going to obstruct the light that comes from the pupil to the retina, and the baby is going to become blind, unfortunately. Now, this condition is called as retrolental fibroplasia. See, this might come as an VSH, so just make sure you know the spelling of it. Retrolental fibroplasia. Okay, just look at this flow chart again so that you understand this concept. Now, final point. The safer side for oxygen therapy is you should not give more than 40% of oxygen to the baby. This is the required value that is being considered by doctors all over the world now. If you're going to give more than 40%, then that can lead to risks like your retrolental fibroplasia. So just keep it on under 40 or on 40 percentage. So with that, we have revised the entire fetal and neonatal physiology. I will be attaching my notes in the description and the annotations in the description. Please go through the notes because it has some additional facts and points, and all the best.